For those of you who I don't know, I'm Washofsky. I'm one of the first-year interns, and Kirsten Madea is my co-chief. I guess you're kind of like my chief today, but my co-senior that will be presenting today. We do not have any financial disclosures to make. So our objectives for today are to practice formulating a specific clinical question and understand the study's design, most likely to yield valid information about diagnostic questions using the PICO-TT format. We'll appraise the article and understand the uses and limitations of clinician suspicion with the help of the critical appraisal tool format for diagnostic studies. And then we'll contextualize receiver operating curves and area under the curve and their use in diagnostic studies. And then we'll distinguish important factors in the determination of internal validity of a diagnostic study, and finally determine the external validity of the article and its applicability in our practice. So, in terms of our clinical question, the population that we looked at in terms of our PICO-TT format were children who presented to the emergency department with potential Lyme disease or exposure. So the intervention in this study was actually the diagnostic accuracy of clinician suspicion, specifically in the absence of erythema migrans. What it was compared to in terms of a gold standard was positive two-tiered serology, meaning the ELISA and the Western blot, and then outcomes were either physician over or under diagnosis of Lyme disease in the ED. So overall, we treated this as a diagnostic question, and the type of study that this study used was a prospective cohort. In terms of the clinical context, Lyme disease has been growing in incidence in Virginia over the past several years. In fact, between 2006 and 2016, the number of reported cases of Lyme disease went from 357 in 2006 to 1,350 probable or confirmed cases in 2016. So that year was actually the second highest year in Virginia's history of having Lyme disease reported. The incidence over that same period went from 4.7 per 100,000 people to 11.6 per 100,000 people, with a 3-year average incidence at 12.1. So that qualifies Virginia as a high incidence state, meaning that there's an average incidence of at least 10 confirmed cases per 100,000 persons for the previous year. So for us here down in Southwest Virginia, the Virginia Department of Health actually makes a table listing of the most common communicable diseases by county. If you look at where we are in the red circle, Lyme disease was the top communicable disease in 2016 for the counties of Roanoke, Botetourt, Montgomery, Giles, Floyd, Pulaski, Carroll, Wythe, and Grayson, all of which are in our service area. They're pretty relevant for us to understand this. Okay. So in terms of the study design, the study was conducted as a prospective cohort through 5 participating EDs, including Boston Children's Hospital, Hasbro Children's Hospital in Providence, Rhode Island, Nemours DuPont in Wilmington, and then Children's Hospital of Philadelphia, as well as Children's Hospital of Wisconsin. So I guess Wisconsin is a little bit of an outlier when you look at that distribution, but that's okay. The study was conducted between June 4th, 2015 and July 31st, 2017. The study did obtain IRB approval, and consent was given to collect blood samples, review the lab results, and perform follow-up to determine clinical outcome for these patients. So, quick review of the pyramid that we all know and love. In terms of hierarchy, we've all been taught that overall in the schema of things, a cohort study is inferior to a meta-analysis or a randomized controlled trial. In this particular case, it was pretty difficult for them to do a randomized control. So a cohort study for this particular question ended up being the best study to use. So the study looked for children who were undergoing Lyme evaluation for disease in the ED. The population included children from ages 1 to 21 years old. It was determined that they were being evaluated for Lyme disease by one of 2 factors. Either they had an erythema migrans rash, or the clinician treating them was suspicious based on their history and ordered Lyme serology. So to clarify, the study used the CDC's definition for defining erythema migrans rash. These criteria include having a single primary lesion that's greater than 5 centimeters in diameter with or without central clearing. A lesion less than 5 centimeters in diameter would qualify if it had occurred at the site of a known tick bite, if there was an interval of time between the bite and the rash, and if the rash was enlarging. So all three of these needed to be present for it to qualify. Finally, if the patients had previously been enrolled in the study but returned and were reevaluated for clinical reasons, they were included. So in terms of data collection, at each site, the clinicians who participated were given standardized training on the procedures of the study. When evaluating the patients, these participating physicians completed standardized case forms while collecting the patient's history and physical exam. The clinicians also obtained information on whether the patient they were evaluating had previously been diagnosed with Lyme disease. Patients were categorized as either yes, having possibly or probably had the disease, or no previous history. Upon seeing the patient, the attending physician in charge of the patient's care was asked to assign a score of the probability that the patient had Lyme disease, 1 being not likely and 10 being very likely, thus creating a clinical prediction rule for the study. In general, clinical prediction rules are tools that have been created through research to help clinicians in making predictions. So they look at the contributions of the relevant patient characteristics to give numeric indices. They can be used to help assess prognosis or classify categories of severity for treatment. In this particular study, the clinical prediction rule was used to assess diagnosis. For our study, the results of patients' Lyme disease serologies were not available at the time that the score was assigned. 1 month after enrollment, staff abstracted the results of all Lyme disease serologies performed within 30 days of enrollment of the study. Additionally, the attending provider identities were abstracted. So in terms of our outcome measures, the primary outcome of this study was the diagnosis of Lyme disease. For the purpose of the study, this was defined as a patient with potential Lyme exposure plus either a physician-diagnosed erythema migrans rash or positive 2-tiered serology with clinical manifestations. It should be noted, though, that because all the participating centers were in Lyme endemic areas, all of the children were considered as having potential exposures. In terms of clinical manifestations, these included EM lesion alone, or signs of early disseminated Lyme disease, such as multiple erythema migrans lesions, cranial neuritis, headache, and or neck pain or stiffness, as well as EKG changes suggesting carditis. Nonspecific symptoms such as fever or fatigue were not included and led to the exclusion of those patients regardless of the results of the Lyme serology. Finally, positive 2-tiered serology that was performed within 30 days of enrollment was included to capture patients who seroconverted later. Positive testing was considered either positive or equivocal ELISA, followed by a positive immunoblot. An IgM immunoblot alone was needed if the duration of the symptoms was less than 30 days or the patient had symptoms consistent with Lyme. So the fun stuff, the data analysis. So to perform the statistical analysis, the researchers basically went through 4 different components. So first, they made a comparison of the children with Lyme disease to those without. To do this, they used the Mann-Whitney-Ute test to compare continuous variables. Please don't ask me how you perform that test. It's way above my level. This test can be used in lieu, though, of an independent sample t-test to compare differences between 2 independent groups, particularly when the dependent variable is either ordinal or categorical, or continuous but not normally distributed. The chi-square test was then used to compare proportions between these groups. So next, they looked at they examined the association between clinical suspicion and diagnosis. So a binary logistic regression was used to measure this association. However, children with an EM lesion were excluded as the diagnosis is more or less confirmed with that finding present on exam. They also used a generalized estimating equation to actually measure the association between clinical suspicion and diagnosis after adjusting for confounders. So, receiver operating curves. Once the associations were measured, the study addressed one key question asked, that is, are the clinicians able to distinguish between children with and without Lyme disease in the ED? The receiver operating characteristic curves, or ROCs, were obtained comparing the true positives versus false positive for scores from 1 to 10. The discriminative ability of clinicians was quantified by the area under the curve, or the AUC, with the AUC less than 0.7 indicating poor discriminatory value. AUCs 0.7 to 0.8 reflected minimal accuracy, and then 0.8 to 0.9 reflected good accuracy. Finally, the prevalence of Lyme based on clinician suspicion score was categorized. So scores of 1 to 3 meant that Lyme was unlikely, 4 to 7 meant that Lyme is possible, and scores from 8 to 10 meant that Lyme was probable. So in looking at the results, overall 3,152 patients were evaluated for Lyme during this time. Of these, 1,414 were approached, and 1,021, or 72.2%, were consented to participate in the study. Most of the patients that weren't included in this, it was because it was off study hours, essentially. The children who were enrolled had symptoms compatible with different stages of the disease. Specifically, 42 of them had EM lesion alone, 479 had early disseminated disease, 467 had late disseminated disease, and then 33 had nonspecific symptoms, so they would not have been included. So of the children enrolled, 238, or 23%, were diagnosed with Lyme disease. To note, the proportion of diagnosed did have a range between 16.9 and 36.4 between centers, so there was some variability depending on the site that they were located at. So of those diagnosed, the diagnosis was made by EM lesion alone in 27 of them, so 11%. 15 of them, or 6.3%, had EM lesion plus positive two-tiered serology, and then 82% had positive two-tiered serology alone. So 26 children, 2.5% of the study population, did have repeat serology that seroconverted within 30 days of the study. So if we're comparing the groups of children with Lyme to those without, the age distribution was pretty similar. Children with Lyme disease were more likely to be male and to be white, but other than that, the p-values were significant, reflecting similarity between the two groups. So this graph doesn't really add a whole lot other than it was interesting to note that they did have diagnosis of Lyme disease throughout the year, including the months of December and January, which are times when we normally wouldn't really think about Lyme as a potential diagnosis. So 99.2% of the patients participating had clinician suspicion scores documented by 216 attending physicians. 74% of the attendings enrolled more than one patient, with a range of 1 to 28 patients enrolled per attending. 42 children were excluded that had the EM lesions initially at presentation. Following that exclusion, increasing clinician suspicion was associated with Lyme disease diagnosis. And then once it was adjusted as well, for patient age, month, year of presentation, clinical stage, hospital cluster, the association higher suspicion score with the increased odds of Lyme were unchanged. That means that for every point in score, there was a 45% increase in the odds of Lyme. So for our little statistics review and going over the results as well. We wanted to review what the receiver operating curves and the area under the curve really represent and how they're important in this study. So an ROC curve is a good way to evaluate diagnostic studies. Technically, it's defined as the plot of sensitivity, which is what we want to see on a good screening test, on the y-axis versus 1 minus the specificity on the x-axis. So for ROC curves, sensitivity really represents the true positives and specificity the false positives. So as you can see, looking at the relationship between sensitivity and specificity on the chart, a decrease in sensitive results would mean an increase in the specificity. The accuracy of the test is also reflected on the graph. The closer the graph is to the top and the left, the more accurate it is. Additionally, the closer the graph is to the diagonal lines drawn below it, the less accurate the test is. So the other way to think about it is reflecting the accuracy on the graph is to look at the area under the curve. So actually, calculating the area under the curve requires a bit of calculus, but the idea is that the greater the area under the curve, the more accurate the test is. So a perfect test would have an area under the curve of 1. In general, an area under the curve less than 0.5 would be considered pretty useless. So roughly accepted grading system is 0.9 to 1 is excellent, 0.8 to 0.9 is good, 0.7 to 0.8 is fair, and then 0.6 to 0.7 is not so good. So specifically for our ROC and area under the curve, the ROC was used for the analysis of 974 children without a single EM lesion. They measured the ability of the clinician's suspicion to diagnose Lyme disease. What they found by comparing the true positives and the false positives was that in the absence of erythema migrans, clinician suspicion was minimally accurate in diagnosing Lyme disease. Specifically, our AUC was 0.75, which kind of qualifies it in the fair range. So furthermore, you can look when looking at the prevalence of Lyme disease based off of these results, that clinician suspicion, it's difficult to do, again, with the absence of the erythema migrans. So looking at this chart, you can see that 540 children were considered unlikely to have Lyme disease, but of those, 65 of them actually did. Similarly, 127 cases were considered likely to have Lyme. 39 of them did not have Lyme, so that's 30%. So that means that treatment decisions, if they're made on suspicion alone, there would be a significant number of children who'd be either undertreated or overtreated. So overall, the study conclusions, children with EM lesion alone can be diagnosed with Lyme disease without having any serology, specifically if it's greater than 5 centimeters. Children treating clinicians' clinical suspicion of Lyme disease before serology results are available is kind of minimally accurate. Clinical impression plays a role in initial management decisions, and physicians appear to accurately incorporate clinical factors into the assessment, but overall there is minimal accuracy. Decision support tools and more accurate and rapid diagnostic testing would improve our care to our patients. And then finally, physicians have to make these initial treatment decisions before serology is available, but final testing and confirmation of the results should always be taken.
Thank you, Dr. Washofsky. So glad all of you are here. So we'll move on to a little more critical appraisal. Dr. Washofsky touched on the results and understanding the area under the curve and the ROC curve. So we'll briefly retouch on that. So you all should have received a sheet in the back, which was the diagnostic critical appraisal tool that we used. If not, you can grab one in the back, and we'll go through these questions together. So are the results of this study valid? So we, first of all, looked at the internal validity. We asked the question, were the methods for quantifying clinical suspicion objective and consistent across the cohort? Were the tools validated where applicable? We said yes, all of them, they received prior training and standardized case forms completed by that clinician. But this case form that they used, there's really no evidence with this grading 1 to 10 with the unlikely to have Lymes or possibly have Lymes or definitely have Lymes with this scale that they used. And there was no point value assigned to maybe a specific finding that they had. So why did the physician choose one number over another? Was it because the patient had a tick bite or in the history, or was there another symptom that made them lean one way or another? So then the next question we asked, was the cohort representative of the population, and was everyone included who should have been? We said yes, and as Dr. Washofsky mentioned earlier, that it was typically those white males that were ended up having Lyme's disease, and the race did differ, but the p-values were significant. And then the next question we asked was the diagnostic test evaluated in a representative spectrum of patients like those in whom it would be used in practice? And so the spectrum of patients chosen excluded those with the erythema migrans. So one could argue that the spectrum of patients that they looked at in this study was not complete because they clearly excluded those that had the erythema migraine rash, and that's the clinical diagnosis of Lyme. And so is this a complete spectrum is the question. So was there an independent blind comparison between the index test and an appropriate reference, quote, gold standard of diagnosis was the next question we thought about. And that gold standard diagnosis for Lyme is the rash clinically. A physician can make a clinical diagnosis on this. And again, that was the group of patients they excluded in their spectrum for this analysis. So they defined their reference standard of diagnosis as the serum Lyme testing, and then they did the index test as their prediction rule, which is the scale 1 to 10 for likelihood of the diagnosis. They did do all of the patients did receive both of these. The next question was follow-up of subjects complete and sufficiently long? And as Dr. Washofsky mentioned, there were 3 patients that seroconverted after 1 month of a time frame. They were retested, and they were initially negative for Lyme, and then they ended up being positive. So why were those patients positive? How long do you need to follow a patient to see if they seroconvert? Or were they re-exposed? Was this a patient that just is hiking 3 times a week? What were the results? And if you look at your critical appraisal sheet, this is where we discuss the accuracy and the precision. So were the methods for determining outcome objective and consistent across the cohort? Were the tools validated where applicable? So all institutions, they did use the same analysis and binary logistic regression analysis, which is a validated tool for any prospective cohort. And as mentioned earlier, the ROC curve allowed the assessment of the true positives versus the false positives, measuring the clinician's accuracy for diagnosis, and the score was in the fair category. And can we apply these results is the question. So were the methods for performing the test described in sufficient detail to permit replication? So we answered this yes, partially. What were the questions the physician were thinking were valid as to how they scored their suspicion on this scale? Did the physician weight any sort of signs or symptoms specifically, and was there variation between how they personally weighted them? And does the history of having a tick bite increase the likelihood of how the physician scored someone? What's the difference between that range of 4 and 7, which was the, well, they might have Lyme's consideration? Well, the physician that ranked a 4 on one patient and then a 7 the next, what was the difference? That's the question. So looking at the external validity and applicability again, will the results change my management? Big question here. So suspicion without that classic erythema migrans rash, then I guess you got to get the serology is the thought process, because we have a study here showing that we're not really good at guessing whether or not a patient has Lyme based on other symptoms at this point. So how long does it take here at Carilion? So if it's during the weekday, it's about 24 hours if it's negative for that Lyme serology to come back. But if it's reflexing to the blot, then it will take another 48 hours on top of that. And if it's on the weekend, it's about 72 hours to get that back. So then the next thought is, well, you know, the treatment for Lyme is kind of a low risk. You can do amoxicillin in these kids under age of 8, so why not treat? Or are you going to end up over-treating? Do you want to fall in the category where you're over-treating, or do you want to fall in the category of waiting for 3 days until you get your result and then treat? But yet it's low risk. So conclusions, as mentioned earlier. So the treating physician's clinical suspicion of Lyme disease before serology results available is minimally accurate in the absence of that classic rash. The clinical impression plays a role in initial management decisions, and physicians appear to accurately incorporate clinical factors into the risk assessment. Decision support tools and accurate or rapid diagnostic testing would improve care. Physicians must make initial treatment decisions before final results. However, those final decisions, you have to await the serology. And then the next thought we had was, what about a point stratification for these clinical findings outside of that classic rash? Will this lead to an improved prediction rule, possibly we could use in the future, and maybe have a better diagnosing process for Lyme? So thank you guys for coming. It was a good turnout. What thoughts do you have or questions? Dr. George. I guess I'll run to the back.
So, sorry, I have a couple of questions. I'm just going to sit up here for a second. And I apologize. I forgot if the serology that they used, did they do it the two-step? Yeah. They did? Okay, I just wanted to make sure. Just making sure that we were really doing the gold standard. My question would be, all right, so what would be the harm of, again, holding out, waiting 3 days? Your overall delay is 3 days in terms of for treatment, other than potentially patient parental angst, anxiety, maybe, and kind of what your thoughts were about that.
No, we had talked about that some, and it's going to be that parental anxiety, I think, that probably leads a lot of my personal plan as to how I would do this. Why not, you know how you have the patient that comes in with the sore throat, and we're waiting on the strep culture, and some physicians will give a script for amoxicillin, and we'll call you in 2 days, fill it in 2 days, once we call and we tell you it's positive. So I think potentially you could do that, but then you're going to have the families and the patients that go fill it, whether or not they actually have Lyme disease. So I think it comes back to, we have to find some sort of grading system for all of these signs and symptoms that are associated with Lyme, and kind of find something that we can use as a better clinical tool. Yeah, who wants next?
I'll take a challenging approach to that. So even though you might think that individually amoxicillin is not significant for that one patient, and in population health it's very significant, and not only are you exposing that child to a drug that they may not need, but you're probably exposing the biosystem throughout for increased insensitivity to using amoxicillin for other things. And in this day of e-faxing, you don't have to send a prescription home with somebody. If your serology came back in 24, 48, or 72 hours, you could just hit a thing and send it over without having to rely on somebody's judgment at home about whether they'll fill that or not. And I think probably we'll never get to more clinically accurate diagnosis because all of these symptoms are very, very nonspecific, which could be for anything. So I would challenge in the way of thinking about stewardship for antibiotic use and also for individual, at first, do no harm, is whether we would be doing any harm and not waiting for 24, 48, or 72 hours to actually accurately treat somebody with the appropriate medicine.
I have a question for you. So one of the reasons you can make the clinical diagnosis if you have the EM rash is that if you do serologies, they'll often be negative to start with. So I'm curious, what's the possibility that you're seeing a child who doesn't have the rash but does have Lyme but has not seroconverted yet? Yeah. And because 3 of those did seroconvert, and I'm curious, how many of those were revisited? I mean, did everybody come back, or no, so you don't know why those 3 were? Yeah. Probably, yes, yeah. That's logical, but anyway, it just made me think, if they come in too early, might we miss them if we're relying on serology?
And when do you repeat serology?
Yes, well, if they have persistent symptoms, I guess.
Yeah.
So I think this is a question about study design as opposed to a comment. I realized that this study ended up looking at over 1,000 participants, but I didn't see in the paper, and maybe I missed it, where they talked about whether they had enough numbers of enrollees to make sure that they had enough power that the findings were statistically significant. I feel like they missed saying in their paper that they proved that they had enough numbers. Like in my head, I'm like, 1,000 patients sounds like, like enough patients, but you know how you're supposed to consult a statistician when you're developing a study to make sure that you're going to recruit enough patients to get a statistically significant study, and I feel like they forgot to put that in there. So it seems like it's enough patients, but I'm not sure.
So in this type of study, you don't necessarily have to do that, because they're not doing like a treatment. Is this treatment going to be better than this one? This is going to cure this or this one. But they're comparing two diagnostic tools. So what they have to do in this study is actually apply the same thing to both groups, so, the ones who are positive or negative, which they actually did. There is one thing here. Both tests, which is the index test, in this case is the clinical decision rule, right, and the serology, which is the gold standard, right? They have to apply to both, to everybody, right? But one has to be independent on the other. However, in this study, the clinical decision suspicion was the one that drove them to actually do the serology, see, to start with, right? So the way they just kind of fixed that in that way is like, if you have a suspicion, then they get the serology, or they get Lyme disease treatment right away if it's a characteristic rash. And then what they did was like, let's evaluate the likelihood, right? So the index test started in the likelihood of, in the score system, 0 to 3, 4 to 7, 7 or more, to actually have accuracy on the diagnosis. So they just took everybody that was for sure away, because those we already know, which is actually clinical diagnosis, or clinical opinion is pretty important, right? And only took into account the ones who have likelihood but no certainty, and compare with the serology. So, so in this kind of test, because in this kind of study, because it's not like you're going to prove this is better than that, or this is going to improve this or that, but actually you're just going to compare a gold standard with another tool to diagnosis. Is this good enough to actually diagnose it? It's not necessary to have like that number, or like it is in other kind of studies.
There's got to be a basement somewhere under you say, okay, this study looked at 250 patients, and what conclusions can we realistically draw from that about clinician accuracy?
For like the 27%, 23%, 1/4 of them having the disease and stuff, you might guess, they do have enough numbers. They wouldn't have enough numbers if they didn't have anybody diagnosed. They cannot really compare anything, but.
Do the numbers of the participants in the study, is that going to affect your confidence interval?
It's not really what they're counting here. They're not counting confidence intervals. They're adding, they are giving you a risk, because they calculated ORs, and they said that for every point extra that the physician will place, they will have 40% more risk of having the disease. So they did also present the data in that way, but they didn't really give us a confidence interval, because that's not what they're really calculating in this study. They are more comparing two different ways of diagnosing something, and then they're not really giving us the results in confidence interval. So it's like a different kind of study that the ones you're used to read with randomized controlled trials, and is the effect here or here, because we're not really measuring an effect. We're measuring a tool. Is this diagnostic tool good enough to diagnose this or that? So it's a different difference.
You bring up a great point, though, about the way that they designed the study, which is clinical decision had already driven the cohorts already. And so, a better way to do it would be to get a grant or whatever funding to test every child that came into the ED for the serology, and then ask the physician, regardless of what happened, do you think this child had Lyme's disease or not? And then do it that way. That would be a much better study, and it would probably be more accurate about assessing whether your clinical decision-making was powered, significantly powered, to be able to make those decisions. But that's a great point that you bring up.
And what we'll see is that we did a ton of serologies in people that didn't need it. And they will see more importance on the clinical decision, too, of actually suspecting the diagnosis. It will be more obvious that it's important to have the suspicion, you know, which I don't want to underestimate our point of view, our suspicion, because we got to suspect it, because this is a bad disease to have. And one of the things that, you know, we cannot take easy, we don't want them to have already neurologic symptoms before we diagnose them. You know, we want to diagnose them before they develop those. And one thing that this study did not do also, in one of the questions that they were saying is like the severity of the disease, were they actually having a good spectrum of patients? They don't only refer to where they were black and white, but also was this the beginning, the day after the tick bite, or was it 2 weeks later, okay? And we do not have information on that in this article. So the severity of the disease at the moment of the presentation is also a very important factor that you have to take into account when you're talking about a diagnostic tool. When the kid was exposed versus when the kid developed the rash, so there is a window there, and it's going to give you like low or more probability. Of course, you can diagnose everybody when the appendix is already boosted, right? Oh, yeah, he did have appendicitis. But what you want is to diagnose the appendicitis when the abdominal pain starts, not when they are already perforated, you know. So same thing here. We have to have a good spectrum, meaning mild disease versus severe disease, and we don't want them to have neurologic compromise, you know, neurologic compromise when we do. Yeah, it was Lyme. You know, we want to do it soon enough. And we don't really have enough information on when in the moment of the disease, which we call a spectrum of the disease, the kids were. So that's, you know, another thing that I would be like, wanted to know in this study that was not reported. And the other thing that you want to know is like, what were the questions, right? Those 10 points, what were those questions, right? Because we want to know, you know, what should I be asking? And then if you have those tools, like a clinician, you can say, okay, you know, if I have 7 or 8 of those, then my probability of having disease is going to jump to 60% or more. Then, okay, then, you know, it will drive you versus, oh, I only have 2, 3 of these questions, so maybe my probability of having Lyme disease is only 10%. So I'll be a little bit more, less weight for the serology. But if he's like 8 or 9, I'll be like, oh, let's treat, and I call you if it's negative and you stop the antibiotics then, you know, or let's treat and they will retest again in 3 weeks and, you know, see what's going on then, you know, or in 4 weeks, which is actually what I do. I don't know if anybody knows that also, like one of the questions that Dr. Madea was saying is like, when do you retest, right? Because we know they can seroconvert. Here everybody was, I don't know if you pay attention, but they say within 30 days. But we don't know exactly when was that retesting. Within 30 days could be a week, 2 weeks, 3 weeks, or 4 weeks, right? So I'm a little bit hesitant to exactly know what they did in that matter. If they retested the next week, they could be negative. But if they tested 4 weeks later, they could be positive. So I don't know if anybody knows more than me on when do they seroconvert most. So usually, my personal practice is usually retest 4 to 6 weeks later. I don't know if anybody knows better.
So I got really excited when I got my new red book in the mail yesterday. But, I do. I have it. I got it. Well, I almost brought it today, but I decided to not. Sorry. No, so standard, gosh. Normally, 2 to 4 weeks, I would say, in general, tends to be the time. So, again, in the end, what are you at risk for by delaying diagnosis and stuff is you're worried about the early disseminated and late disseminated diseases. And so how long of a period of time is that before, like, you know, those would potentially develop? And with the early disseminated, you know, up to anywhere from 6 weeks or so. Talking about 6 weeks to 2 months is when that would potentially develop, and then 3 months or so, we're talking about the late disseminated. So that's where kind of partially the thought of when would you retest. So give it another good 2, 3, sometimes 4 weeks, depending on, again, what kind of clinical history do you have to drive your suspicion. Was there a tick bite, this, that, or the other, that literally just happened versus one that might have been a couple of weeks ago.
Thank you. Anyone else?
Is anybody on the line, Officer?
The conference is now in talk mode.
You're on the line, have a question?
All right, well, thank you all for coming.